before before we start, بس as a scaphoid topic in general, I know إنه كتير ما من الروتيشنز أو as an orthopedic في السعودية ما بنشوف كتير hand stuff لكن I think scaphoid is one of those important topics اللي احنا we need to keep a keen eye on بسبب إنه it's associated a lot with a lot of other injuries such as disc fractures. فاليوم حنتكلم إن شاء الله على different objectives من الموضوع بعد كده we can if we have time we can discuss a couple of cases كمان. Please if في أي أحد عنده سؤال سواء يحب يكتبها أو يسأل على طول ما في مشكلة. If there's any point ما هي واضحة كمان قولوا لي ممكن نعيدها مرة ثانية. The topic is not very long بس إن شاء الله it will be covering almost everything. وحركز على النقاط كمان اللي هي مهمة for exam points اللي بتتسأل عليها كتير. Okay? Okay, let's start. Sorry. طيب. So we'll go with a small case. We have a 45-year-old medically free patient presented with history of fall down. He has a wrist pain. هل في أحد يحب ياخذ بس أول حالة؟ It's just a general kind of review of how to examine, how to do stuff general. في أحد حابب يبدأ؟ Anyone? No one? Okay, it's fine. Fine. History in general, what would you like to ask in a patient with a history of fall down, مع أي patient with a wrist injury? It's important to ask about the mechanism of injury, the pain analysis اللي كلنا عارفينها. When did it start? How did it start? Is it radiating? What type of pain it is? It's all important عشان تعرف إذا كان بيتكلم على more of a neurological symptom. Is it more of a fracture symptom? Is it more of a sprain? The intensity of the pain. Past surgical, past medical is very important. Medication they're taking. Occupation is very important as well. هذه لما تبدأ في practice as well, it's important to know what kind of occupation that the patient does. If someone has a more of a labor-intensive kind of job, their expectations or their needs of their hands are much higher. Sometimes the type of job they're doing بيديك إذا كان لازم يرجع للشغل بسرعة، إذا كان أبطأ. Hand dominance as well is very important as well. Smoking is very important, especially in our topic. بسبب الأشياء اللي هنتكلم عليها in a point in vascularity wise. So in any hand injury or any wrist injury, طبعا you gotta go for a sprain. You gotta differentiate if it's disc fracture, scaphoid fracture, carpal bone fractures, and so on. Okay. So examination wise, we're just gonna run through it quickly. Inspect. For any wrist injury, we can inspect if there's any open injuries, any deformities, a dinner fork deformity مع distal radius, إذا كان في any suspicion of hematoma in a suspected place, any position the fingers are on, they will give you an indication as well as it can be other tendon injuries or it can be other fractures as well. Palpation. Now, palpating a wrist is very important. طبعا differentials are a lot, it's different. Palpating for the carpal bones is important, especially the scaphoid, where we're going to palpate it in a second. But the simplest way of examining a wrist is going in a circle. Start from the radial styloid, going dorsally, inspect the bone, inspect on the joint surface, and so on. At least it will give you an indication of what is the problem, at least give you a hint of what it is. Range of motion. طبعا range of motion is زي ما عارفين if any injured person عنده ألم, it's not as important, but it's important for the clinic for a follow-up later on. طبعا that's the patient who came with us with this injury at this point. Does anyone know any special test, since we're talking about scaphoid fractures, any special test that we can do for detection of scaphoid fractures? Left bulk tenderness, that's one of them. Anything else? Axial load, exactly, and with the radial axial compression. Perfect. So, as mentioned, radial deviation with the compression on the scaphoid would give you pain as well. It elicits some pain. Snuff box tenderness. طبعا snuff box is around this area. It is called snuff box anatomical snuff box عشان كانت في يابان في أمريكا وأيام كان يسموه كان use it for cocaine. كانوا they sniff through it. That's why it's called the snuff box tenderness. A volar tenderness of the scaphoid tubercle. So when we palpate on the volar aspect over here, it gives you, so in these tests, it will give you a little bit of kind of a hint of where the fracture is. If you have a snuff box tenderness, it's usually kind of a waist kind of injury. If it's on the volar aspect over here, it is more commonly on the proximal pool. Okay, so it's not very specific, but this just give you kind of a way to think of where it is. So to how to diagnose this طبعا احنا في اي حاجه بنسوي x-rays. طبعا x-rays of the wrist is very confusing. I would say بالنسبه للcorpal bones, if you don't get to see a lot of lateral x-rays specifically, هيكون مرة صعب انك تعرف بسبب ال overlapping of the shadows. So it's very important to see x-rays over and over طبعا until you get very familiarized with it. طبعا في special view فلما تشوف ال AP you gotta identify what type of bone are we looking at. Scaphoid, lunate, pisiform, tracheatrium, hamate, capitate, trapezoid, trapezium. انا عارف ان دائما صعب انه الواحد يذكرها بس نحاول انه دائما at least every time we see an x-ray you're suspicious of anything, you got to go back and look at it. What are we seeing? So a special view for a scaphoid, it's always a scaphoid view called the 30 degree of wrist extension and 20 degrees of ulnar deviation. So why are we doing this? طبعا احنا زي ما احنا عارفين السكيفويد is not directly upright في الاناتوميكال position حقتها. It's always flexed with a little bit of going a little bit of a radial deviation. So once we apply the other kind of angles to it with the 30 degrees extension or 20 degrees of ulnar deviation, it will give you a full view of the scaphoid in an extended view. But you can see the whole waist as well. This and now let's say the x-rays are normal. انت رحت في شفنا patient came to you, you did the axial loading, you did your test, and you have a very high clinical suspicion. What to do next? First thing you can do, is the simplest way you can do, is you go for putting the patient in a splint or a cast, immobilize, and repeat examinations in 2 weeks. In 2 weeks, usually you start having some resorption around the fracture site, and it shows some lucency around that area. That's how we usually diagnose it. المشكلة إنه إحنا عندنا في السكيفويد, as we mentioned, it's a bit flexed. The trabecula are difficult to see. So إحنا أحيانا, if we don't angulate the imaging properly, you will not able to see the whole scaphoid waist fracture. So other modalities, طبعا احنا by the book we know other modalities that we talk about are CT, MRI, and bone scan. But what to use and when to use it, that's always the question. Bone scan is not a common modality to use, although it's very sensitive in the first 72 hours, high specificity and high sensitivity, but it's very hard to diagnose what type of fracture that we need because we're surgeons. We need to address it in a surgical manner or a non-surgical manner. So bone scan will not give you that information. A CT scan is what we usually use in practice, to be honest. معظم الاشياء اللي انا بنسويها ما بنستخدم لها ام ار اي. هنتكلم على الام ار اي والكلام هذا بعدين for other stuff. بس a CT scan is most common used modality. It's important to put a 1 millimeter cut and you try to put it on the axis of the scaphoid itself, سواء انت عن طريق السوفت وير اللي عندكم او عن طريق الراديولوجيست. It can give you if there is a fracture, assess the type of fracture, and also in follow-up. You want to know if it's uniting or not, so you know how to proceed with your management. MRI, as we is by the book. This is the most common question that بيسألوا, what is the most sensitive or the best modality in في exam in the first 24 hours? It's usually MRI, but the access to an MRI is very hard. Okay, I wouldn't say it's the number one modality that we're using. And in a chronic condition, it's MRI is important to assess the vascular status of the scaphoid. عشان هنتكلم دحين عن classification and anatomical problems with it as well. So this is the research was done. طبعا في أماكن that we were talking about, is it clinical and cost implication of using an MRI? Does it outweigh of doing X-rays for every patient? So they calculated everything and they got the patients. I think this was done in the UK NHS in the United Kingdom. لما بيستخدموا MRI immediately instead of follow-ups with X-rays until you diagnose it, it showed lower cost in general. Implicating a good healthcare system that has an easy access to MRI sometimes helps with reducing the cost in general. Okay, so important anatomy. Why is it called a scaphoid? Scaphoid is derivative from the Greek word scaphus, meaning a boat. Looks like a boat. It is the most common fractured carpal bone, 68%. And then it is covered by 80% cartilage. It does not have a lot of tendons attached to it or anything. It's mostly ligaments that's attached to it. We're not going to dive into ligaments. It's a very complex topic, but we'll not dive into it today. It's important to understand that we have two vascular supply to it. We have the superficial palmar branch of the radial artery, which supplies 20% of the scaphoid. And then we have the proximal, the dorsal carpal branch of the radial artery. They both supply the scaphoid coming in a retrograde nature. فلما بيتكلم على الفاسكولاريتي, the more distal the fracture, the more vascular it is, the more chances of it uniting. That's why there is more, as we mentioned before, the modalities that we're using as a CT scan, as an X-ray, it gives you an indication of where is the fracture. فلما يجيني fracture with a distal pool similar to this one here on the left side, I would be very comfortable with not treating it operatively, just with a casting. بس إذا جاني واحد with a proximal pool fracture, I would be very concerned about it. I would keep him under observation. I would be more keen on fixing it because fracture stability improves its healing potential. And as you go proximal, it goes from 100% union rates up to 333. Some literature says up to less than 10% as well. Why is scaphoid important? It has a lot of articulations. It's very important in the mechanics of the wrist. As you can see here, when you flex your wrist, the scaphoid flexes with you with a radial deviation. And once it extends, it goes in extension with an ulnar deviation. It gives you this dart thrower motion. This is an important motion in rehab sometimes for some ligaments because you're working on this motion with the scaphoid itself. But this is going to go with the flexion radial deviation, extension ulnar deviation. Okay? So when do we suspect a scaphoid fracture? A patient came in with a radial sided wrist pain after a forced hyperextension and a radial deviation of the wrist. It's very common مع slips and falls. And طبعا عندنا هنا في Canada with the ice and everything, it's very common. في السعودية عندنا it's more common مع أشياء زي fall down واحد بيلعب كورة أو لما أو بيطيحوا أو عندنا road traffic accidents as well. So it's very hard to assess that. فالنقطة المهمة هنا, if a patient came with a distal radius fracture, it's very important not to get distracted from other fractures. Scaphoid is easily missed. I would say that I've seen more missed scaphoids than acutely diagnosed scaphoids in general. I'd say it's 8 to 2 تقريبا, the amount of missed scaphoids. So why is that? Why is the scaphoid usually fractured with this kind of hyperextension and radial deviation? And why is the most common fracture is the waist fracture? Let's look at the anatomy of the scaphoid. Once the wrist is in extension or a loading in it, the proximal pool is protected by a lot of ligaments, by the radius, by the capitate. It's all protected from fracturing or moving out of place. So the distal pool is kind of free. It doesn't have a lot of attachments from a bony perspective. It does have some attachment like the STT ligament from the trapezoid and trapezium, but it's not as strong as bone. Um, and the proximal scaphoid is supported with that hyperextension, yes, and عندك distal radius fracture, and also hyperextending of the scaphoid once it starts impinging. That's why waist fracture is very important. It's very common. It's more common than any other fracture. Okay, so we understood why do we have a scaphoid fracture, why is it important. So how do we classify it? Is it important? من الآخر, it does not import at all what type of classification you use, because there is not a certain classification that gives you an indication of what kind of surgical management you want to do. The only classification that I honestly use is if it's a proximal pool, waist fracture, or distal pool. ايش هيفرق معانا؟ هيفرق معانا من ناحية المانجمنت سواء operative أو non operative. وفي operative management our approach of surgery as well, which we're going to talk in a second. Herbert classification, I've never been asked about it, to be honest. For acute and chronic, stable and unstable, doesn't matter as much. But what's important is measurements. Interscaphoid angle is the only measurement that you need, to be honest, to have a sense of how bad of a fracture it is. This is usually applicable more, I would say, in the scaphoid waist fracture. It gives you, you take a sagittal cut, the biggest sagittal cut in a CT scan, وبعدين you draw a line, as you can see, on the proximal pool, distal pool, and then a perpendicular line intersection each other. Once there you have an angle more than 35 degrees, then you're concerned about it being unstable, having a humpback deformity. I don't know if anyone heard about it. It's called the humpback deformity, where the scaphoid itself is flexed, so it has a humpback in the back of it. So what is the classification for a criteria of instability? What these are all, we're going to come back to that slide again. It's going to be the exact same classification for what is indicated for surgery. So once we have an 1 millimeter of fracture displacement, once we have an interscaphoid angle of more than 35 degrees, we have massive bone loss or comminution, and malaligned fracture, a proximal pool fracture, a DZ deformity, or a perineate fracture dislocation. Now, I'll just talk quickly about a DZ deformity. DZ deformity is basically a dorsal tilt of the lunate due to the injury between the scaphoid and the lunate. We have the radiolunate ligament, the scapholunate ligament, sorry, where the SL ligament gets injured, causing this motion with this tilt dorsally for the lunate. But with the fracture, it does not have an injury in the ligament itself. It's just because of the fracture, the proximal pool is extending as well. So that's an indication for surgery, because that alters the biomechanics of the wrist. Now, that's a very different topic. We can talk about it later in a different time. So a patient came, you've diagnosed him, you've done your examination, you've done your CT scans, you know what you're facing. So this is the algorithm of treatment usually. So suspect scaphoid fracture. If it's displaced, you do an upper reduction tendon fixation. If it does not seem to be undisplaced, and you do a CT scan and it's not displaced, you can do a cast or an ORIF. If the fracture is seen, not seen, sorry, and repeat an X-ray in 2 weeks. By the book, an MRI is indicated. By a CT scan was also very helpful in diagnosing this type of fractures. If it's normal, there is no scaphoid fracture. If there's abnormal signal with an MRI, you can cast or ORIF, because if you don't see a fracture, it's most probably non-displaced. Okay, so you had a scaphoid fracture, waist fracture, and it is non-displaced. You went for a conservative management. So what type of conservative management can we do? Cast immobilization is usually what we do. So when you have a discussion with the patient, هيسألك المريض, how long is it going to be casted? Honestly, it is different from one patient to another. You got to go back to the factors that we talked about: the patient age, the type of fracture, where is the fracture, is he a smoker as well? All of these delay your union. So it goes from 6 weeks up to 12 weeks sometime. Um, as you go more proximal, you got to go for a longer immobilization. Now, the question is, do we include the thumb or not? Do we do a thumb spica or not? Interestingly enough, there's most people are like, it doesn't make any difference. But this article published in 2014, it showed that interestingly, thumb free group had higher union rate. Could that be due to the micromotion in it? Could be. Why is it exactly? We're not sure, but it usually doesn't make any difference. So whenever someone says put the thumb spike on it, I don't think it matters. I don't think it makes any difference. And I actually think the patients have decreased range of motion in the thumb and more stiffness, which bothers them much more than you think. So does surgery reduce time as well to union? Now that's part of your discussion. It does. So a lot of research was done according to X-ray and CT base, and it showed that there is a decrease in the return to a union rate. But does it make a difference? هذا السؤال. Like, does it make difference in the long term? If a patient came with and he said the choice is up to you, you got to talk to the patient. Okay, it is a a faster union rate, but return to work was due to the SWIFT research was done in 2020 in the UK as well. It showed that there is no difference in return to work. There is no difference in pain and no difference in healing. The only difference was a faster healing. That's all. But on the flip side of things, هيجيك المريض يقول لك طب خلاص, let's fix it. You got to talk to the patient. But we have a lot higher complication rate, 10% more complication rate. And that includes anesthesia risk. A lot of patients could die from anesthesia as well. We had a patient last week. Last month we did a bicep repair, a simple 45-minute procedure. He sustained the PE and died. It's probably from the surgery itself. So you got to keep that in mind as well. Other complications, including arthritis, including hardware failure, infection. So you got to keep that in mind. Cost is also something you got to think about, especially if you're working in a private sector. It's almost 4 or 5 times higher cost to fix them. So you got to have that kind of balance in your head once you back into practice. طيب جينا المريض وقلنا احنا we want to fix him. So what's the indication? As we talked, the Mayo classification of instability is the same. You've got 1 millimeter fracture displacement, scaphoid angle of 35 degrees, bone loss or comminution, fracture malalignment, proximal pull fractures, DC deformity, or a perinate dislocation. These are all indications for fixation. This is the humpback deformity, as we talked about. So it's important to correct that deformity as well. So surgical fixation. What are the options available? You've got K-wires, you've got plates, you've got screws. I think the gold standard nowadays is putting a screw through it. There's a lot of variables on what is a perfect screw. So when someone says, like, what is your best screw position? You want it to be covering as much space as possible in the scaphoid. You want it to be as perpendicular as possible on the fracture. But let's look at this X-ray, for instance. عندنا fracture is a little bit tilted. So if you don't put your entry point properly, you're not going to have that kind of perpendicular to the fracture screw trajectory. Sometimes even if you aim it properly, it's very hard to get that perpendicular. So you want it to cover as much space of the scaphoid itself. And when you look at this X-ray, you might be also looking at is this protruding? Is this going to be a problem with the joint? Most of the time, it's not. There's, as we mentioned before, 80% of the scaphoid is covered by cartilage. When I promise you, إنه كل مرة بنشوف الإكس راي هذه في الكلينيك, we're like, oh, it might be out. It is not, because it's always embedded in the cartilage, and you can't see the cartilage in X-rays. Plates, it's been used here and there, to be honest. It has a trend now for the US. I've tried it before in more of a course. I wasn't a fan of it, to be honest. It's a bit too finicky as well, and it feels like it's going to impinge on something. I would rather have a screw embedded. K-wires, sometimes you got to go for K-wires just because of the comminution. And a screw with the compression is a problem. If it's too comminuted, sometimes putting a compression through that comminution might displace everything. So sometimes K-wires is your go-to. So what approaches do we have? This is an important slide. This is kind of summarizes what approaches do we have if you have depends on the fracture where it is as well. You've got the volar approach and dorsal approach. My preference personally is if it's a proximal scaphoid or a waist scaphoid, I go a dorsal approach. If it's a distal scaphoid or even a distal 1/3, I would go for a volar approach. A waist fracture, it's a surgeon preference. You can go volar or dorsal, but any proximal pull, you gotta go dorsal. Any dorsal pull, any distal pull, you gotta go volar. Okay, so this we use the FCR and the radial artery. It's kind of an extension of a Henry approach. And it's indicated by the book for distal pull fracture and humpback deformity, because you want to correct it and put some bone graft as well in it, where just to correct that deformity. I've been using the dorsal approach and correcting that humpback deformity, and it's been sustaining well. I feel like it's easier to do it that way, but it's still a surgeon preference as well. Now, does it matter as well regarding union rates? I don't think so. But also, when they mention dorsal approach, there's always care about the blood supply. So you don't want to take a lot of the soft tissue on top of it. It's very small vessels that come through and supplies the dorsal aspect of the scaphoid, but it's important to preserve it as much as possible. Okay. So some of the pearls that we can find from operative management. Do not compromise your guide wire placement for incision length, meaning a mini open is the same as a percutaneous. I would say a mini open is 10 times easier than a percutaneous. A mini open takes around 5 minutes to get to. You see where's the scaphoid. You can fix the screw properly. You're not going through tendons. You're not impinging on anything. I think it's much better. Okay, this is how they go for a percutaneous scaphoid fixation for the volar aspect. I don't know. The problem with this one also is when you go with the volar approach for the scaphoid, this is technical pearl. Once you do your approach, the part of the trapezium or in the trapezoid is going to be in your way. So we usually take a chunk out of that. It doesn't affect stability whatsoever, but we got to take a piece of it عشان نحط عندنا an entry point for the screw and the K-wire properly. Some people have talked to you about what's their way of doing it. If they go volar for percutaneous, they go through the trapezium and the trapezoid. Does it make a difference? I don't think so, but I think it's much harder to go percutaneous in these ones, and it's a lot of X-rays as well. So once you put in a K-wire, put it a bit, see how weird trajectory, and then if it's fine, continue with it. You don't want to put a lot of K-wires, because once you put a lot of K-wires in back and forth, it's very hard to put the proper K-wire in. If you put a K-wire, you're not happy with it, leave it, put another K-wire. It helps you with the trajectory as well. So there's two types of headless compression screws these days. You've got a partially threaded and you've got a fully threaded. A partially threaded, it's important to understand that you want to cross the fracture site. So make sure when you look at the X-rays that your threads are not in the middle of the fracture, proximate to the fracture. Okay, so with these type of fully threaded compression screws, you don't have that much of an issue, and it's very strong with the compression, by the way. So any questions about the management in general قبل ما نخش في الcomplications ونتكلم عن grafts in general? Any has any questions at all?
دكتور عبد الله، سؤال بالنسبة للبركيو سكرو. I heard you
اتفضل.
say about removing part of the trapezium. Is this for
Yeah.
all percutaneous scaphoid or just like the ones with the overhanging trapezium?
Sorry again, if that's for all of, you
Yeah.
said all of the scaphoids, ولا?
Is that you're gonna do percu screw? You're gonna remove part of
So
the trapezium?
yeah, no. So percutaneous, you're not going to be because you're not opening anything. So you're not looking at the trapezium. So as I mentioned, if you're going percutaneous, I've done one for residency, but obviously we did not open it up. But I was talking to a couple of surgeons who did a couple of percutaneous. They go through the trapezium as well. So the K wire is through the trapezium and the scaphoid. Then they drill through the trapezium and the scaphoid, and then they put the screw through the trapezium, but it passes the trapezium and it just in the scaphoid by itself. So the screw is not in the trapezium itself. They just go through it with the drilling part. Once you do an open approach, you take a chunk of the trapezium because ما حتقدر تشوف distal pool or your entry point for the scaphoid to put your K wire properly. It will impinge on it. It's not going to be easy to do. Any other questions? Um, so yeah, so what else? So it's appropriate to do CT scan acutely if X-rays are negative. Um, I think it's very reasonable to do it sometimes. Honestly, it does show sometimes the fracture. Um, it's usually in the 2 to 3 week marker where we use the CT scan. But it's not wrong as well to do CT scan in the ER. If you have an easy access to the CT scan, it does show it sometimes. It's just when it's very minimally displaced and very subtle. If you don't have proper CTs, you might not see the CT properly. You might not detect the fracture. So an MRI will give you the high intensity visuals, and you can be like, okay, there is a fracture there, so I need to address it. So CT scan is very reasonable to do in the ER if you have a high suspicion about it as well. Okay. Any other questions before we move on? Okay. Okay, so this part is a bit advanced, but it's very important to understand as well. I think if you have any question, if they're going to ask you any questions, they're going to ask you about everything we talked about before. Technically, not much, but this is for your own knowledge. The complications, apart from what is the most common complications, and you got to be careful about it. Okay. But the management is just for your own kind of also knowledge. And if has anyone questions, we can talk about it a bit more in detail. So non-union is the most common complication with the scaphoid, as we mentioned before. What is viscous non-union? The more than 1 millimeter of displacement, delay in diagnosis and management, more than 4 weeks, location of the fracture, and history of smoking. So we notice here we did not talk about the humpback deformity. We did not about the scaphoid angle because it will not be a cause of non-union. It will unite. It will unite it will be a malunion. And as we mentioned before, scaphoid is a very integral part of the motion and the mechanics of the wrist. So once it's injured, and it's uniting in a malpositioned, in a malunion, it will affect the motion on your wrist. A patient ممكن يجيك بعد ال5 6 سنين يقول لك I am having some pain بسبب انه I'm not able to move my wrist. I feel like it's blocking. That's because of the malunion about it. But that's less common. Non-union is the most common problem. So how to treat a non-union? There is an algorithm to it, null and Trumbull algorithm. Now, everyone's going to tell you something different, but this is the by the book. This is what they see by the book. If you have a waist fracture and you have an AVN in it, after the MRI, obviously, you can use a vascularized bone graft with a dorsal approach for it, or you can use also if you have no AVN, you can go for a volar approach and put the screw through it. If you have a proximal pull, you can go for a vascularized bone graft dorsally with a dorsal approach if there is no AVN as well, because as we said, proximal pull. Now, this is I want to just mention, I've gotten these from some of my mentors as well, these algorithms and and what we do here differently. So this is what Green reference says. Okay, if you have a delayed union, a mini open with a compression screw is indicated in this point. And I will ask a question now, and let me you guys tell me what you think. Now, establish a waist non-union, no deformity, no arthritis. You can do a bone graft, dorsal or volar. Non-union with a humpback deformity. By the book, it says volar approach, okay, and using a bone graft. But as we said, I prefer, and that's what I've been trained to as well, is doing a dorsal approach. A proximal pull non-union, you can go for a dorsal approach, use a bone graft, and so on. And then if you go for an MRI, a devascularized non-union, you got to use a big chunk of vascularized bone graft. Now, the question that I want to ask you, احنا بنتكلم انه we always have a late union or بسبب vascularity in a scaphoid. So how do we know if it's a delayed union or a non-union? Like, what is the cutoff? Is it the same as other bones? I don't think so. I think a lot of the time, a delayed union is diagnosed as a non-union prematurely. So, a research we're working on as well, where even delayed unions, we're talking up to 9 months to a year, where we see that the fracture is non-displaced, but there is non-union in it. It is not a vascular problem as well as sometimes it's a mechanical issue. So we've been putting screws immediately into it without doing an MRI, without doing any vascularized bone graft. And so far we've had a 100% union rates in these fractures. So that raises the question, are we overdiagnosing non-unions and using vascularized bone grafts? I think we are to a certain extent. Okay, so that's just a point of discussion. But again, you got to go with the book for exam. Um, so, what are the types of bone grafts that we have? We have non-vascularized bone graft, iliac crest, or a distal radius. I think we have a question. Is there a cut point to say this is a non-union or a delayed union? Honestly, by if up to 2 to 3 months, up to 6 weeks, and you do a CT scan, um, and you see it's 6 to 8 weeks. If you don't see any part of healing at all with the CT scan, I would say that's a delayed union. So when we call it delayed union, it's not that it's not completely healed. It's not healing. It's not completely healed. Because at 6 weeks, you want to see a full callus bridging or full crossing through the fracture site. So 6 to 8 weeks, if you don't see anything, I would be more keen on fixing it, to be honest, especially if you go for non-operative management. But if we put a screw in it, I would wait for it a bit longer. So maybe 2 to 3 months or even more before I address it with something differently, to be honest. Does bone scan have a role in evaluation non-union versus delayed union? Um, I don't know. I honestly don't know. I haven't been using bone scan. I don't know if the literature says anything differently about it, to be honest. But I'd have to look into that. And if I find something, I'll send it to you guys. Okay. So, benign vascularized bone grafts, as we mentioned. the most common is using an iliac graft or a distal radius. Another question, would the judgment differ between proximal distal pool in terms of union timing? Yes. Um, in a distal in a proximal pool, um, most of the time I would not treat it non-operatively. I would say 90% of 99% I would treat it with a screw. I think the difference is not the union rates in the proximal pool. I think my concern would be more of the vascularity or avascular necrosis. So I would keep an eye on it. If I see in this X-rays some sclerotic or some increased intensity in the proximal pool, I would be more keen to do an MRI to diagnose it as an AVN, especially if the patient has pain with it, and then I will address it. If it's a distant pool, I would never address it, to be honest. I would just leave it because it's most of the time does not affect function whatsoever. So the question is, non-vascular bone graft, does it matter? No. So instead of going for an invasive procedure in the iliac crest, I think a distal radius it has enough bone graft for you to use in a non-vascularized manner. And you can use a bone chunk if you're using also a part of the cortical bone to put it as to correct the hemback deformity sometimes as well. This is a non-vascularized bone graft. Vascular bone graft, we have a lot of options. Personal preference is the one to intercompartmental supraretinacular artery. It's called a Zeidenberg graft. We take a piece of the bone graft here, and then it's a dorsal approach. We take a piece of the bone graft here, following up the vascular of the artery itself. We take it, we stuff it here, and then we put the screw dorsally. That's why I prefer doing it dorsally. It's very hard to do it from the volar aspect. You have volar carpal artery as well, the Mathelan bone graft, but it's not commonly used. It's very finicky and it's very hard to find as well. A pronator quadratus is also a part of it. You can take a part of the muscle attachment with the bone graft and put it in. Again, 1-2 is what has been the workhorse. And this is also to keep in mind, different people, different practice. I've worked my first year with the plastic surgeons, and this year I've been working with the ortho surgeons. All of the plastic surgeons believe in a dorsal approach. A lot of the ortho people believe in a volar approach. Preference again. So let's see this, for instance, this patient, 17-year-old female, right hand dominant hockey player. This is one of the patients we saw slashed in a hockey 1 year ago. She had this fracture. Okay. So 6 months after putting it with a 1-2 vascularized bone graft, we see that it has healed nicely. It had good wrist extension and good wrist flexion, 80 degrees. So they do very well with these kind of fractures. And this is more of a waist with a lot of comminution. We've also used a bone graft in this one, also 1-2 vascularized bone graft with a volar also approach, and they heal really well. Now the question, we're going to talk about it in a second as well, and this is the patient as well, 4 months post-op. Very good range of motion. Now, if it's a proximal pool, another option is a medial femoral condyle graft. This is a very technically difficult case. If you use a vascularized bone graft in these cases and put it, they do unite. But the problem is, like in this case, as we said, they put a screw in it. It did not unite. So they used a medial femoral condyle flap. And it's very technically difficult. The 1-2 vascularized bone graft and the bone grafts with the screw takes around 45 minutes to be done. This takes 4 to 5 hours to be done, and you need a vascular surgeon with it. Once here, they kind of took the defect over here. We can see the defect, and they stuffed the vascular part of it, and then fixed it as we see here, and it has united as well after, and they took the screw off. Not commonly taking the screw off, but in this case, they took the screw off. Okay, so does it matter? That's the question. It seems to be not. Now, this is again the issue. We're all talking about, does it matter if we put a non-vascularized bone graft? Does it matter if we put a vascularized bone graft? No difference in union rates in that review article published in 2022 between non-vascularized and vascularized bone graft. Now, let's take this with a grain of salt. Are we talking about a waist fracture? And are we talking non-union, or are we talking AVN? If we're talking a waist fracture, non-union, okay, using a vascularized bone graft or a non-vascularized bone graft doesn't matter. But if you have an AVN, I think it kind of gives you a push more into a vascularized bone graft, a medial femoral condyle, or a 1-2 vascularized bone graft to have kind of a better outcomes in general, or better expectations of what the patient could get from these. Okay. Okay. So let's see all of this. We've done all of this. What is the end complication? Why it's a non-union? It's not big of an issue. We'll leave it. Correct? Some would say that. Now that's the problem. You develop what's called a snack. This is an important topic as well. It's very high yield question as well. Scaphoid non-union collapse. We go back to the same question, same topic we talked about, mechanics. If the scaphoid is fractured and it's not uniting, the carpal bones are all working together. If it's intact, if it's fractured, the carpal bones start shifting against each other. So it's kind of rubbing on each other, causing this snack. And it has stages. It starts with a snack type 1, which is a radial styloid arthritis. Type 2, scaphoid fossa starts having some arthritis. Stage 3, capitulonate is also involved with the arthritis. Stage 4, diffuse arthritis. And we don't want to get into that stage 4, because once we get into that stage 4 as well, sometimes it's too late for us to do any kind of minimally type of fusion. We sometimes go all the way to a wrist fusion. Okay, so if we have stage 1, all we do is the radial sidedectomy. As we progress to type 2 and 3, the options are four-corner fusions, which is basically a partial fusion of the wrist. So you lose almost 50% of your wrist range of motion. But in type 4, sometimes we even need to go for a full wrist fusion. So you don't want to go into that point. Okay? All right. So that's the topic, and I think that's the most high yield stuff that we can talk about. Any questions about the management? Any questions about any of this stuff that we talked about?
Guys, feel free to unmute yourself and ask the question if you want.
Okay. Denervation for SNAC/SLAC instead of PRC for advanced stages. So denervation, I don't think it's not a proven thing to do. It's written there. We've done it for patients who are young. It doesn't always work. It's not as reliable as something as doing a four-corner fusion. Now, a PRC might not be also always viable as an option. So let's talk quickly about PRC versus four-corner fusion. In these cases, a four-corner fusion would be a bit better if we get to that point, because you're going to have, as we mentioned here, one second, as we said, in stage 3, capitulonate arthritis. So a PRC is not a viable option in stage three, sorry, because if the capitate is arthritic, PRC is contraindicated, and PRC, um, some literature showed that PRC is does have some weaker grip strength than a four corner fusion. So in these cases, we prefer doing a four corner fusion plus a denervation with it, to be honest, because we do that easily in front of us with the PIN and AIN neurectomy as well. Any other questions? No role. Um, so first question, no role in replacement arthroplasty and snack. No. Um, Replacement arthroplasty is more commonly used for elderly patient with OA. I would say ممكن تستخدموا replacement and arthroplasty if it's an elderly patient with a very low demand, which is very uncommon. I'd say most of the scaphoid fractures that we get are younger patients or middle-aged men with a missed scaphoid fracture coming with a snack. So most of the time, they need still their grip strength. So we do a partial or full wrist fusion. So it's not as indicated for it. And also replacement and arthroplasty is not still not the gold standard, but they do very well for older patients. Another question we had, did you do PIN neurectomy in each dorsal approach? Yes, I'd say almost all of the dorsal approaches, because it's basically once you do your approach, um, you go under the fourth compartment of your wrist extensors, and it's there. That's where it's bed. It goes under the fourth compartment, and you just take it off, and then you go through the intraosseous membrane just across it from the dorsal approach. You can see the AIN as well. So you do a neurectomy as well. The PIN and AIN does not have any nervation in the wrist except proprioception. And there's one patient that came back, said that I'm having a proprioception problem, but all of them doesn't have it. And he regained that proprioception issue, but otherwise it does not affect patients whatsoever. Any particular parameters rendering proximal pool unreconstructible? How do you usually decide? Um, so if it's a very small chip, there was a case I saw as well, um, where it's a very small chip where they did approximate pool excision. They just took it out for it not to bind. An unreconstructible is honestly if it's very small, you go intra-op and it's just too small to be fixed. If it's completely avascularized as well, I think that's due to the MRI. It's if it's completely avascular, I think that's where you want to go for kind of a medial femoral condyle um, um, fixi graft. Now, there's one point that's a bit I haven't mentioned, to be honest, which is similar to what very close to what you're talking about. Let's say a patient has a proximal pool completely avascularized, completely gone. You don't want to, you don't, it's unfixable. You can't put a screw in it and so on. You've got other options, to be honest. There is a literature that's done for the Mayo Clinic last year that suggested a hemihamate. We take a piece of the hamate, the proximal part of the hamate, and replace the proximal pool of the scaphoid. There's other literature where we did also taking part of the a rib cage, second rib cage. I think it was the second rib cage, where you take it with a piece of cartilage and replace the proximal pool. The question is, does it have a good outcome? Now, you have two things you want to focus on. A good outcome meaning no pain and good range of motion. With these parameters, you can get the same outcome. Instead of doing these cases, you can do a four corner fusion. So there's a lot of people with the idea of why should I go through all that trouble? Let it go into a four corner fusion and he would have the same outcome. So, but you can also try in a younger patient, 18, 19, 20-year-old patients where you do a proximal pool replacement. All right. You're welcome. Thanks for the question. Any other questions before we end up here? الله يعافيك. شكرا لكم شباب، إن شاء الله تكونوا استفدتوا وبالتوفيق إن شاء الله يا رب.
يعطيك العافية دكتور عبد الله، ما قصرت، الله يكتب لك.
يعافيك يا رب.
الله نشوفك في
الله
لقاءات
يعافيك.
أخرى مستقبلا.